Unmute yourself, please.
Hi, welcome everyone. Thank you for joining us on this Wednesday afternoon. Apologies in advance if I sound like Sylvester Stallone. I just had a dental procedure and I'm a bit numb, but welcome. GECO is hosted by the Gastro Foundation in association with Project ECHO of the University of New Mexico. As you know, these sessions are held weekly on a Wednesday with alternating topics. And the chat will be open from now for questions, so please feel free to post your questions in the chat. Today we have a speaker, Dr. Vuyo Soldati, who trained as a colorectal surgeon in Cape Town and is currently working at Prasani Baragwanath as well as the Pittstoner Gordon Hospital. He works with quite a large and experienced colorectal team. He's got interest in rectal cancer as well as in intestinal failure. And he's going to be talking to us about a very topical and important topic. Now, this topic has been evolving in the last few years. There's been a lot of work coming out from the Netherlands. I think the Dutch are probably the leaders in the field, and they move into quite a large cohort of their patients are being treated conservatively with the view of organ preservation. And this has been facilitated by advancements in endoscopic therapy, advancements in minimally invasive surgical therapy, advancements in oncology as well with checkpoint inhibitors. And the outcomes that we're getting now with total neoadjuvant therapy or TNT. So organ preservation in the rectum has been very topical, has been a big topic in the last 3 years. And so we look forward to hearing all about it from Dr. Soldati.
Um, Thank you for that introduction, Vikash. Let me just share my presentation again. There you go. Can you guys see that?
Yes, we can.
Just get onto. Oops. Okay, perfect. Thank you for that introduction. As Vikash said, I'm going to be talking about organ preservation and rectal cancer. And because I know this is mostly a medical audience, I thought I'd also just get into the role that endoscopist plays, as Vikash has sort of touched on. There's a big move towards sort of trying to preserve the rectum and move towards local resection strategy, either using EMR, ESD, or the microsurgery like TEMS. Okay, start off with the usual slide. As we all know, common cancer is really exploding internationally. It's now become the third most common cancer in the world, with about 2 million new cases a year. And at the rate it's growing at, it's going to hit 3 million by 2040. It's also now the second highest cause of cancer-related death. And its highest incidences in the sixth decade of life, although it's getting younger and younger. I put this slide up because it's important, number one, for perspective, that while we are looking to get gains in function and cosmesis, we're still dealing with a very deadly disease. And number two, though we mustn't ignore function, especially because the incidence is just getting younger, and the age of incidence is getting younger and younger internationally. So since the 90s, TME has been standard of care for rectal cancer, really of all stages. And this has become the gold standard to which all alternative treatments are compared to ever since the Dutch TME trials. This, of course, as described by Bill Heald, involves the removal of the entire rectum along its embryonic plane as one parcel, really being one of the few operations where you can grade the specimen that will speak to the quality of the oncology and really relate to at least local recurrences. And indeed, the TME operation has reduced local recurrence as well as improved overall survival in rectal cancer. Problems, though, are that as much as it's improved oncology, it's a long procedure, and patients in their sixth, seventh decade of life often have other comorbidities and are high-risk patients. What we have done to further improve oncological outcomes in terms of local recurrence and systemic recurrence is now in the advent of TNT, giving radiotherapy and chemotherapy up front, gives you a patient who's slightly more frail and a rectum that's had quite high dose radiation, and this has implications in terms of anastomotic leakage, which is a huge morbidity we have to deal with in terms of operation for rectal cancer. Another issue that faces us in terms of this TME is ostomy rates, whether you end up having to do a full APR with a permanent colostomy. Sometimes you do a low anastomosis and you defunction it with ileostomy in hopes that you will future reverse it. But in some patients, you end up with leaks, chronic leaks, and or patients who are just unfit for further surgery and end up really having permanent ostomy is a significant problem. Pelvis, where we operate, is an area that's fraught with nerves for urogenital dysfunction and urogenital function and sexual function. So, combination of radiotherapy, operating within that area, and infections from leaks really leads to a significant amount of sexual and bladder dysfunction. Then, of course, once you've gone through all of that and you've closed your stoma, then there's the low anterior resection syndrome, where you've got a patient who's excited to finally have their ostomy closed, only to find that they are either having pain or bleeding or struggling with continence once they have been put together. So this condition really does prevent a lot of challenges just outside of the oncological challenges. To try and address this, we've really evolved our approach in how we approach rectal cancer. Traditionally was the open surgery until the laparoscopy trials came in and proved non-inferiority to open surgery. With this, you of course reduced recovery times and hospital stay, but it didn't solve the problem of leaks. It didn't solve the problem of ostomy, stoma function. In fact, you can probably get a little bit lower still open than laparoscopically and stable at a lower stage. So it didn't solve that. And didn't solve leaks, didn't solve stoma formation, and didn't solve the problem of sexual and urinary dysfunction. Then we thought the new boy, fancy boy in the house, robotics, would come and solve all of this. And really, robotics has been big expenditure, but not very big gains. Initial big randomized controlled trial was the ROLA trial. Disappointingly, didn't show any improvement in sexual function or urogenital function, nor did it reduce leak rates. But what it did show was improved conversion rates. Then sort of the Chinese came in and came with these large randomized control trials and systematic reviews. And there, when you really dig in the weeds, you start seeing that hospital stay can maybe go down from 7 days to 6 days. Conversion rate, 3.5%, I think by all means, is a fairly low conversion rate that they had laparoscopically. Internationally, you're looking somewhere around 5%, but they managed to lower that. And also with the robot, you can get lower than laparoscopically and staple lower. So they were able to get a lower APR rate, which meant less ostomy rate. Then there was a big systematic review of all kinds of studies of robotic surgery, trying to weed out to see if we can find any better functional outcomes. So a few studies were put together and they seemed to show that there was better urine retention scores, slightly improved sexual function, but unfortunately there was a bit of a mixed match of quality of life scores used that, and we weren't really comparing apples to apples. So it sort of was being deemed as sort of low quality evidence, and we still don't have definitive proof. Although there's lots of studies going on to try and show gains that you can get from robotic surgery. Okay. And then enter the endoscopist. I mean, at this stage, TME was really the be all and end all for all kinds of rectal cancer. But then there was a thought, I don't know if it is by design or by accident, maybe in terms of taking out big polyps, we ended up with a few T1 cancers, and we thought, hey, this is something we can do. This is a little bit out of my comfort zone and more in your comfort zone. So, as Jacob Zuma would say, listen carefully. So, advanced polyps, the T1 lesions, and early cancers, we've now realized that you could take out quite safely endoscopically as long as it's a low risk lesion. And we've set a couple of rules in order to facilitate this so that we don't end up going for lesions that are still more favorable, are high risk for local recurrence or systemic recurrence, and therefore need more aggressive surgery. So endoscopically, as you all know, you've got the Paris classification, where most of the pedunculated and subpedunculated lesions are good going. Flat lesions, and you really start to have to worry where you're starting to get flat depressed or proper depression, and then obviously full-on excavated lesions are a no-go. To augment this, we've got chromoendoscopy, where we've got Kudo and JNet. Again, this is a surgeon's very simplified view. I'm sure it can get a bit more complex. Where really you can look at the surface and vascular pattern to try and grade the risk of invasive disease and whether or not you should be biopsying or taking out a lesion. And if you do go for a resection, knowing which kind of lesion is going to need an end block excision so that it can have margins properly assessed. So based on these two, if you are going for a Kudo 5, the one that's irregular, not the unstructured, or if you're going for a JNet 2B, those lesions, you probably have a higher risk of having invasive disease. And in those cases, you're wanting to make sure that you've got one clean specimen with margins and not sort of a piecemeal resection. Further, we take our specimens and send them off for analysis. And from there, you've got your Haggett for pathological analysis, and then you can use your Haggett classification for pedunculated lesions to try work out the risk of recurrence. And basically, everything from Haggett level 3 back to 0 is quite safe to take out. Level 4 being the level where you've got submucosal invasion and you really need to start worrying about nodal involvement and risk of local recurrence and distal metastases. Similarly with Kakushi, sorry, I see that come out a little bit blurry. You basically divide the submucosa into thirds, slowly approaching the muscularis propria, and it's the SM1s really that have the lowest risk of nodal involvement. And really what's acceptable is you want a risk of nodal involvement below 5%. So if you're looking at SM2 and SM3, it was felt that those patients would not be suitable for endoscopic mucosal resection because of the risk and would rather go towards TME. So at this stage, what we had is the patients that you can approach with endoscopic resection were those, or you can be happy with the endoscopic resection were those tumors you've resected, where you've got a T1 or TIS that's negative for EMVI, not poorly differentiated, are not resection, Haggett 3 and above. If it's invading the submucosa, then you want SM1 and a low tumor budding score, and preferably lesions that are 3 centimeters or less. These are what you call low risk T1 lesions. and just local resection alone is adequate. Initially, at the stage, it was TME for the rest, which I've gone into and spoken about all the problems associated with it. Then entered these bad boys into the market. There was a big uptake of endoscopic submucosal dissection and endoscopic intermuscular dissection, and also for the lower lesions where the surgeons can find some relevance. So this you need patient lesions that are at least within 8 centimeters. Some will say 12 if you've got an extension. 10 centimeters if you've got an extension shade from the anal verge. So here you can either with the ESD go straight for the take fully the submucosa and expose the muscularis layer, then you know you've got the full submucosa and you're looking for a lesion. Or if you think you've got a lesion that's going into muscularis propria, then you can go between the circular and longitudinal muscles of the bowel wall. In this way, make sure you've got an R0 resection. Similarly, with TAMIS, you're basically doing laparoscopic surgery, but through natural orifice for low lesions. And just like ESD, you'd lift it and go, but you'd go with some kind of energy device. But what you will appreciate when you look at these pictures is that on this TAMIS picture, the surgeon has really gone into multiple different planes, whereas on the ESD picture, you can see this is one full intact plane. Either they've taken just some mucosa or then in the intermuscular plane. So there is some nuance, and there are guys like Vikash had said, the Dutch, who are quite good with that TAMIS or TEO and making sure they stay within that intermuscular plane. But it takes quite a lot of training to get there. Okay. So now, once we realize that we've got these tools and we can get there into those planes, a few studies were conducted to see what do we really have to go and do a TME for all lesions that are not T1 low risk? Because at this stage, if it's not a low risk T1, the whole rectum would have to come out. So first trial to go through is the GRECA-2 trial, which is a prospective randomized open label multi-center trial. So what they did here is they took patients with T2, T3 tumors with a maximum size of 4 centimeters, and they gave these patients neoadjuvant long-course chemoradiotherapy, which was 50 gray of radiotherapy and some sensitizing doses of capecitabine, and basically looked for what's called a good clinical response. So the tumors must basically be more than half its size, so less than 2 centimeters. Less than half size, sorry, so less than 2 centimeters. Those patients, so 145 out of 186 achieved this, the rest didn't and went for TME. Then they said, okay, now we've got these in-between lesions that we are going to try local excision for instead of a TME. These were all rectal lesions and they all had TAMIS. But what they did is because we know that anything beyond a T1 still carries significant risk of nodal disease. If they did the local excision and the pathological grading was T2 or T3, then the patients fell off and went for TME. The study, when you looked at the patient that just had local excision alone, in that small group did prove that there was equivalent oncological outcomes with improved functional outcomes. Unfortunately, because there was such a high crossover rate, because most of the tumors were T2s and T3s after local excision, and lots of patients crossed over to TME, they weren't, on the overall analysis, able to prove superiority. So it was a little bit of a disappointing outcome, but at least it did show that for those that do downgrade, even if it was a T2 or T3 before, if you're able to downgrade it with radiotherapy, you're able to locally resect and in that small cohort have improved functional outcomes and preserve organs. Okay. Then you had the Dutch who did the TESA trial, which is actually still awaiting outcomes. But here they looked at the basically indeterminate and intermediate, and high-risk T1 lesions and two lesions with no nodes. And what they would do is do upfront local resection with TAMIS, and then if you had a high-risk T1 or T2 lesion, remember the low risks, TAMIS was enough. High-risk T1s or T2 lesions would then get adjuvant chemoradiotherapy. Randomized between adjuvant chemoradiotherapy versus TME. So they've released some preliminary findings that seem to show at 3 years, that seem to show equivalence. No, sorry, before 3 years, that seem to show equivalence in terms of oncological outcomes with slightly improved functional outcomes, but they're yet to publish their long-term outcomes. So we await with bated breath for that. Okay. Then the Americans thought, with all of these studies that are showing, that are looking at radiotherapy for T1, T2, and maybe some T3 lesions as well, instead of going straight for chemotherapy. Radiotherapy is still known to be toxic, to still predispose patients to LARS, to still predispose patients to sexual dysfunction, to still cause a relative degree of urinary dysfunction. Why don't we look at giving neoadjuvant chemotherapy? And this thought really came from the TNT trials, because the TNT trials showed that if you add chemotherapy to radiotherapy, you suddenly get even more clinical response from your lesion. So came Prospect. And Prospect really looked at T2 node positive, T3 node negative, and T3 node positive patients. And gave these patients, randomized these patients between Folfox, which was 7 cycles up front or 8 cycles up front, versus chemoradiotherapy. And then they would reassess, and then the patients after this would go on and get their TME. While the point of Prospect wasn't to look for organ preservation, but rather to establish equivalence between neoadjuvant radiotherapy and chemotherapy for patients who are being treated that way. What it established was that, in the next slide, that you have actually equivalent complete pathological responses. So if you take those patients, you take a group, half give them chemo, take half give them long course radiotherapy, and then take them to TME. On both sides, you had fairly equivalent complete pathological responses. Therefore, meaning if you look back at the Greca trial and even the Dutch TME trial, instead of radiotherapy, you could potentially give those patients chemotherapy, either neoadjuvantly, then resect, or adjuvantly for those patients that have high risk features on their resection. Okay. Then we take it a step further and we start looking at locally advanced rectal cancers. So these would be high-risk T3 lesions that are within 1 millimeter, or some define it as 2 millimeters of mesorectal fascia, or T4 lesions, or nodal disease. Some will say all nodal disease, some will say N2 disease. So this is really the group where we've really struggled with local recurrence, well, highest risk, let's say, of local recurrence and systemic recurrence. So the first people to bring this idea was a group from Brazil led by Habergamer, that basically took a group of patients that have locally advanced rectal cancer, and gave them neoadjuvant. At that stage, everyone was getting either a short course or long course radiotherapy neoadjuvantly, followed by a TME. But they were the first to decide that they would add some chemotherapy to this. And what they did is they gave 50.4 gray of radiotherapy, as well as 5-SU and leucovorin neoadjuvantly. They'd give the chemotherapy first, and then, the radiotherapy first, then they'd give chemotherapy, and then wait 8 weeks, and then they'd do an assessment of response, looking to induce a complete clinical response. The patients would be assessed with a digital rectal examination. You can see it was back in the day, they did rigid proctoscopy, and if they found any suspicious lesions, they'd biopsy them, and then they'd also do a CA level and MRI or endoanal ultrasound. Those patients that had incomplete clinical response or near complete clinical response would actually undergo a local excision, and then those who had no complete response would go to the watch and wait arm. And then they would have follow-up visits. They had a very intensive follow-up protocol where they saw patients every 1 to 2 months for the first year. And in that 1 to 2 months, they'd do a digital rectal examination, rigid proctoscopy, and a CA level. And at 6 and 12 months, they'd do a CT and an MRI. And then after 1 year, they'd sort of increase their surveillance period to every 3 months for the second year, and then 6 monthly afterwards. What they found was a 72% complete clinical response rate in T2 and T3 lesions and 63% in T4 lesions. I must say, so this sort of brought a little bit of excitement, and we thought that we were now going to see patients move away from a surgery, and the vast majority move towards this watch and wait protocol and organ preservation. So this also brought by the age of TNT, where before you would give radiotherapy with a long course or short course up front, resect, then if there's high risk for recurrence, give adjuvant chemo. Now the chemo was brought to the front. And one of these regimens was called, or regimes is called Rapido, based on the Rapido trial, where they basically compared traditional long course chemoradiotherapy to TNT, which was 4 cycles of first short course radiotherapy, followed by 4 cycles of FOLFOX, and then wait 4 weeks, then assess. So it gave a little bit of at least an 8-week wait, roughly. They included very high risk lesions in this study. So T4s, lots of nodes, even pelvic sideward nodes, mesorectal deposits were all part of the study. And interestingly, their findings were with the group with the TNT had a 30% complete clinical response rate as compared to 14% on the long course radiotherapy. The study did kind of come under a little bit of fire because they gave short course to very high risk lesions, which was not standard of care at that stage. And on the 5-year follow-ups, they did have a slightly higher than normal local recurrence rate. But there were some technical flaws in terms of the kind of radiotherapy beams they used and all sorts. So it has still survived, even though it had lots of criticism of their 5-year outcomes. Along with it came the Prodige 23 trial, where they used a very aggressive regimen of 6 cycles of FOLFIRINOX plus long course radiotherapy, and compared that to traditional chemoradiotherapy. There they found about a 28% complete clinical response rate, probably owing to the fact that they did their radiotherapy last instead of induction, and therefore they were assessing very quickly post-radiotherapy. Had they waited, I suspect they would have had more. But what they were going for was reducing local recurrence rate and distal recurrence rate, which they achieved. But however, in spite of that, overall survival was still the same within the groups. But it still gave us a basis for how we can induce complete clinical response and move patients towards organ preservation. And then the main trial really for organ preservation was the OPERA trial, run out of state, which is organ preservation in patients with rectal cancer treated with total neoadjuvant therapy. In this trial, they randomized locally advanced rectal cancers into one arm where that had induction chemotherapy, either 5 cycles of Capox or 8 cycles of Folfox, followed by long course radiotherapy, and then surgery. And the other arm was 50 to 56 gray of radiotherapy as induction radiotherapy, then followed by consolidation chemotherapy, and then for those needing surgery to surgery. Both arms had similar disease-free survival rates. What was interesting was that the patients that had induction chemotherapy had a 41% complete clinical response rate, and those patients that had consolidation chemotherapy, half of them had a complete clinical response rate. However, it's important to know, and this really carried out through the trials, that somewhere between 25% and 30% of patients experience a local regrowth within the first 2 years. And those patients would need a TME. Overall survival was similar across groups. So this opera trial, those patients who had there were two groups. Those patients who had a complete clinical response and those who had a near complete response. And those who had a complete clinical response entered the watch and wait arm, which was a 3 to 4 monthly sigmoidoscopy and rectal exam, a 3 to 4 monthly MRI of pelvis, 6 monthly CEA, and that last one, I said annual MRI, was annual CT scan to look for distal disease. I've just put up a few pictures because it can be quite tricky to decide what's a complete clinical response and what's a near complete response. And if you look at these pictures, really, you just have this pale sort of scar without any ulceration. However, the picture on the right, there is still a little bit of a cavity. But in that patient, when we compared with the MRI, we were happy to call that complete clinical response. You obviously always see sort of this vascularization around this radiotherapy response. But this is generally what it looks like when they have a complete clinical response. Contrast that to what we'd call a near complete response, where you have this pale scar, but there's still sort of like this red edge with some irregular friable tissue. If you look at this last one here, you can appreciate that there's actually still an ulcer. Now, if you see a patient like this and you were really wanting to go for organ preservation, then it really depends on the timing of your endoscopy. So OPERA showed that to get best response from your radiotherapy, you really need to be assessing somewhere between 16 and 20 weeks post radiotherapy. So a lot of times, traditionally, we used to assess patients at 8 weeks, but you need to give the radiotherapy a lot of times. So if you're faced with a patient like this and you're assessing them somewhere between 8 to 10 weeks, standard now is we bring them back in 4 to 6 weeks again for a reassessment. Obviously, you don't want to push it too far because there's the fear of a regrowth. But if you want to go for the organ preservation, then you really need to wait it out and see if you're going to get more response. And in fact, this has now been incorporated into the latest ESMO guidelines, where you can see there that if you look at the different treatment protocols, local excision has become part of your armamentarium for treating T1 in node disease. And even these T2s and T3s, they can sort of swing their way around back there. If someone wants, I'll show you on the next slide, to go for organ preservation, you can give them neoadjuvant treatment and then bring them back towards a T1. And then sort of these T2, T3 lesions, based on the prospect trial, you could give them neoadjuvant chemotherapy and then followed by TME. Although, as I said, there's the TESA trial trying to look to see if you can locally resect these patients. Or you could give them neoadjuvant chemotherapy and then that way induce downstaging and give yourself the option of local excision. The high-risk patients, which are the ones I've discussed in these last 3 studies, are now recommended for TNT. Obviously, some will have a complete response, and those who don't will go towards TME. So, as I said, there's now a new algorithm that looks at localized rectal cancer and lower and middle third rectum when you're going for organ preservation. So T1, T2 lesions, I think if it looks like a low-risk T1, you can still go ahead and resect it up front. But you can induce by giving chemo or, long course or short course radiotherapy. For those patients that are T2s or T3s with some localized nodes, you can now, on top of your chemoradiotherapy, give a booster dose of endorectal brachytherapy, or you give TNT to really downstage them to try and get the complete response. If you've got a complete response, then you watch and wait. If you're near complete response, then you do a local excision. And that's really where things are going. Same for the high risk patients, at the moment, the only patients that we've got evidence for preserving their rectums are those who go on and have their complete clinical response. However, there's a lot going on in the background, with the biggest of the trials being the Star Trek trials, trying to see if you have a high-risk patient and you get them a near complete response, is local excision feasible? Okay. Then, of course, there's the exciting group, which is the patients with mismatch repair, and there's the famous Memorial Sloan Kettering trial that was published in 2022 and the New England Journal of Medicine that used PD-1 blockade for these patients. It's a very small study, and it showed 100% complete clinical response rate in these patients. I think these were mostly colonic lesions. This is what they'd only published their short-term outcomes. I think they are meant to soon publish their 3-year outcomes. So we wait with bated breath. So, there's a lot of studies one could go to, and it's a very broad topic. But I think what I really want to bring to your attention is that rectal cancer treatment can no longer be protocolized. There's a lot of nuance and a lot of individualized care based on what you are trying to achieve. Are you looking for organ preservation? Are you looking for functional outcomes? Of course, without compromising long-term outcomes. What's the genetic status of your patient? And as Vikash said in the beginning, there's lots of research developing at the moment, especially in the T4s and then also in the T2, T3s, to really try and move away from this massive operation and move towards our organ preservation. Of course, there's a delicate balance between oncological outcomes and functional outcomes. And while we want to improve function, you do not want to compromise of overall survival and tumor-free survival. And as I said, there's lots of studies going on. I think I'll end there. Thank you.
Thank you. Thank you very much for that very comprehensive overview. You basically touched on all stages and everything with rectal cancer. There's no questions in the chat, so maybe I can just make one or two comments. First thing I think, and I have no doubt Fuyo will completely agree with me, as an endoscopist, please do not tattoo the rectum. It's a cardinal sin to put tattoo into the mesorectal plane. You will make endoscopic resection and surgical resection a complete nightmare. Please do not tattoo the rectum. There is absolutely no need to put a tattoo in the rectum. That's something that we should definitely move away from. And I completely agree with Vuyo. It's becoming so complex, and the more we learn, the more confused we get. And the more trials and the more techniques we get, the more confused we get. And I completely agree about individualizing therapy, because even on an endoscopy front, things have evolved as well for the early cancers. So we have showed you that we used to consider SM1. So if you have SM1 involvement and you have a curative resection, we used to consider it a curative resection, basically, because your risk of nodal disease then is less than 2 to 3%. And we used to consider SM2 and SM3 higher risk T1 cancers because of the higher risk of nodal disease. But even that has changed and evolved. So now what we're learning is that if you have SM2 or SM3 cancer with no other high risk features, so you have no lymphovascular invasion, you have no tumor budding and no poor differentiation, that the risk of nodal disease that we thought was, I think you showed 23%. So we're finding now that that risk is actually not there. It's actually probably more in the lines of 7 to 8%. Now, while that 7 to 8% might be more than the 5% risk that you said we accept, um, again, we're talking about organ preservation and quite big surgery. And there's important things to remember. So if most of these patients, like we said, are older and they do have comorbidities, and we need to factor that in. We also need to remember that nodal disease does not actually translate into distant disease. They different. So metastatic disease and nodal disease are not the same thing. So we've learned now with EAD and with other techniques that SM2, SM3, as long as you get an R0 resection and have no other poor histological features, it is a reasonable option to just watch those patients and take that 7 to 8% risk. 'Cause, I mean, if you're talking about 7 to 8% in a 85-year-old with comorbidities, that's a very acceptable figure. Maybe in a 30-year-old, that 7 to 8% number is not so acceptable. So we have to individualize therapy. Um, we went into the intermuscular plane with endoscopy, so that has allowed us to take out. It's more for SM3 cancer. And because if you're doing an ESD and you're in the submucosa, chance of you getting an R0 resection with an SM3 cancer is going to be low. But if you dive into that intermuscular plane, you can get a good R0 resection. But we're also diving into full thickness resections endoscopically. So now we can do endoscopic full thickness resections, as you can do with TEMS as well. So we can also do full thickness resections, and we're even personalizing it now. So sometimes, look, we use the JNETs and the Kudos, and we showed you all of those complicated systems, but we still sometimes get it wrong. We're actually working on a study with the group in Belgium where we're looking at something called the muscle retraction sign. So now we do an ESD, we make a tunnel. In the tunnel, we can actually see the tumor, and we can actually see it quite well, and we can actually see whether the muscle is retracted. If the tumor is sitting near the muscle but not into it and the muscle is retracted, then we step back and we dive into the intermuscular plane. If we see this tumor going into the muscle and the patient's a poor surgical candidate, then we dive in and we do a full thickness endoscopic resection. So even with that, it's very individualized. And I think what we're going to move towards is getting more precise biomarkers and trying to predict the risk of distant disease, nodal disease, and distant disease a little bit more, and then individualizing therapy. So we're even starting to incorporate neoadjuvant therapy with endoscopic therapy. So you do an endoscopic resection, you get an R0 resection, and then you're going to have a very low rate of local recurrence, but you still have the risk of nodal disease and distant disease, and potentially incorporating that with chemoradiotherapy. if we go into the intermuscular plane with EAD, we preserve the mesorectal plane. So we don't actually take away the option for surgery, and you can still go for a mesorectal excision. So things are becoming very, very much personalized. And like I said, the more we learn and the more techniques we have, the more confused we get and the less we know what to do for our patients. But we certainly need to individualize it. And I think we made that point very well, functional outcomes versus oncological outcomes. Problem, and I think we need to have more of these oncological sessions, is that as medical gastros, and I speak from our own personal experience here, we're not trained with an oncological mindset. And I've only started, diving into that now since I'm doing endoscopic oncological resections, and I realize the importance of that. But we don't have an oncological perspective in mind, and we don't actually understand these things too well. So it's very evolving field. It's quite dynamic, and personalized and individual care, I think, is the way to go. And I think that emphasizes the points of an MDT. The MDT is crucial. You have to evolve a full MDT for all of these patients. It's absolutely important for all of these patients. Yeah, so it's an evolving field, and there's also now a role, and I'm not sure if you come across it, Vio, perhaps you can comment. So TNT, and then even in this, and it's very much in its infancy, and we don't quite know, but TNT, and you get a near complete response, and you have some residual local disease. Now there's even becoming a role for endoscopically removing that local residual disease, and that is becoming an option, although it's quite challenging because you get the fibrosis after radiation. Did you see anything about the role of endoscopy after TNT?
Yes, absolutely, Vikash. And that's what I was sort of mentioning slightly towards my end. So there's a big Dutch trial that's coming through, and then the British, which was name I forgot, and then the British one is called the Star Trek trial. And both of those are looking at if you take these big cancers, give them TNT, and you get a near complete response. That tumor there, if on MRI, it's looking like it's not going beyond the muscularis plane, having a go at a local resection of those. And the trials have been going on since about 2022, I think. So we're gonna start getting outcomes, I suppose. No, they stopped at 2022, so we should be getting 3 outcomes soon and 5-year outcomes soon, something like that. Yeah, but very exciting
Yeah.
field. I think just to say, I mean, just listening to you spoke, I think here we are very privileged to be in a place where you've got an endoscopist that's uh, keen and eager to go endoscopically. I really can't emphasize enough how you can't now just say rectal cancer, TME. It's getting very complicated, and with precision medicine, it's going to get even more complicated because now we're going to combine all of that with circulating tumor DNA in the blood and prognosticate that way and see where things are going. And there's going to be more and more patients uh, that are suitable for some kind of immune checkpoint inhibitor or biologic. And this field is just going to evolve more, and it's going to be impossible actually to manage rectal cancer outside of an MDT because the decision-making algorithm is just going to be so vast. Yeah.
Yeah, I agree with you in terms of liquid biopsies and circulating DNA. That's going to be another form of surveillance, and it's also going to probably dictate where we go forward as well. So, completely agree. That's going to change the game as well. Um, just remember, and I mean, while we're talking about all of these advanced therapies, and we're talking about all of this, and we're looking at all of these studies and all of these outcomes, I think the reality and the problem, like you mentioned, is that these therapies are still limited to very few centers, and that's where a large proportion of the problem comes in. It's all good having a discussion about ESD versus TEMIS, but if you don't have the expertise and if you don't have availability and if you don't have radiotherapy available to you, then it's still very much a problem. I mean, it's becoming quite a debate about endoscopic therapy versus surgical TEMIS, and there's these studies, and people are saying, endoscopic therapy, and there was the DSE TEMIS study that came out. It was published this year, preliminary release last year, and it was a non-inferiority study for ESD versus TEMIS, and it did show non-inferiority with slightly higher technical success rates for ESD, but lower cost. But again, I think we had a personal discussion about this, and he raised a good point. I mean, looking at studies in centers who have been doing ESD and endoscopic intermuscular dissections for the last 15 years, they are experts. They have a great wealth of experience. Their ESD outcomes are great. And I mean, we got to bear in mind that all of these studies are done in expert centers where they have the expertise. And what we need is local data. We need local expertise, and we need to know ourselves. So we should actually audit our own practices. And if we can't achieve the same rates there, then just because that study shows ESD is comparable to TEMIS, that doesn't mean that's going to translate into your practice or into your center. So you need to individualize therapy even based on your own expertise and your own experience and your own outcomes, just to make it even more complex and to further, yeah, add some complexity to it. So it's. I mean, it's a minefield. It's very, very, very difficult, and yeah, I think we're quite privileged. We have quite a good experienced team and a good MDT. But a lot of centers don't have that, and we've got to acknowledge that's a major limitation. I still don't see any questions in the chat. If anyone would like to say something or ask something, please do. I know
I,
this is a complex topic.
I see.
Vuyo,
I
go.
see. There's Julian Utley there in the group. Any comments, Julian?
Vuyo, I feel like a dinosaur. I grew up with nothing except TME. In fact, introduced it to South Africa, and so this is all like Star Wars as far as I'm concerned. So no, I was delighted. It was a fascinating presentation, and thank you very much.
Thanks, Julian. Appreciate your input.
Okay. I think no other questions or comments. Anyone else? Any last comments, Vuyo, before we close?
No, just thank you for the opportunity to speak. And I really hope this sort of inspires really centers around the country to make sure they encourage their med gastros to also get involved and upskill, because I really can't stress how important it is to have all the options available to you, because some of these patients really, they have early lesions and can't tolerate a big operation, and it's crazy to then say you can't do anything. So I really think we in South Africa, we have some of the expertise and there's training opportunity, and we really should push to try and make sure that we spread the skills around. Yeah, thanks.
Absolutely. I think that's the crux, training. We definitely need more training, both from a medical gastroendoscopic front, from a surgical front, from all fronts. I think that's what it really does boil down for us, and that's how we enter the conversation with these cancers, because we haven't quite entered the conversation with the Western world. So I think that's where it all needs to start for us, training. Yeah, and hopefully we are making some strides to evolve that. I know we are working on some of that at Tono Gordon as well. With that being said, I'm going to close. Again, thank you, Vuyo. I think that was an excellent overview. I mean, you went from start to finish and gave us a lot of perspective. Probably confused us, but I mean, that's the reality of the disease. There is no easy answer to it. And again, thank you to ECHO University of New Mexico and the ECHO India team. Thank you to Cheryl for putting these meetings together, going through the time and getting the speakers and all of the behind the scenes admin together. The recordings are available on the Gastro Foundation website. Thank you to the Gastro Foundation and Prof. Castanidis. And thank you to our sponsors. Just the final, once again, thank you to Vuyo. I think we definitely need to be doing more of these combined talks where we actually having MDTs and educating surgeons, medical gastros, radiation oncologists. We need to actually get pathologists involved. It's very complex, even just looking at the pathology of these resection specimens. With that, let's close. And next week's session is on IBD. So we hope some of you join us for the IBD session. Thanks again, Vuyo. Thank you.